So actually, I think in Duchenne specifically, we are at a point where science has finally rocketed. We are at a point that there are a lot of therapies, medications that are coming out for patients, and a lot of clinical trials that are coming. Uh, One of the things I see and I keep saying is that we have to be worried also about their care, right? Because as much therapies we have and research comes, we're going to have patients living longer. After the standard of cares were really put in practice, and after we start using steroids, the patients used to die around 15 years of age. Today, they can live into their late 20s. Now, with the type of therapies we are having now, we're going to have patients living way, way older. So in their 40s, 50s, hopefully 60s. So one of the things that I'm concerned and I always wanted to bring attention to is that we do have to worry about transition of care, and we have to worry about who is going to take care of these adults as they get older. And I think that exactly like you said, it is a pediatric disease because it is a genetic disease, right? Usually diagnosed in the first 5 years of age. And hopefully at some point, even diagnosed through newborn screening, if we get to that point. So as a pediatric disease, when you have neurologists that train in neuromuscular medicine on the adult world, they don't get much exposure to these conditions. And I think that is one of the first things that needs to change, is that those adult neuromuscular doctors has to spend more time on the pediatric side to learn about this condition as the patient, start transitioning more and more to them. It is hard. It is a very complicated thing to do. I came from a pediatric system where I was able to see patients only up to 21 years of age, and then I had to transfer them to the adult world. But unfortunately, if you had private insurance, you had a place where to go. If you don't have private insurance, that's where it becomes more challenging. So one of the reasons we actually opened our place as a nonprofit was to be able to get help from foundations like Cure Duchenne to be able to keep pediatric and adult patients through life, and to provide those services as a continuum instead of breaking that right at 21. Still, 21 is something I don't understand. In those diseases doesn't change anything. It's still the same condition, right? I think there are several issues, and let me just restate what I said. One, you have to train people, adult neuromuscular physicians, to how to care for pediatric conditions. That's number one. Number two is, the problem is that in general institutions, academic places, or even private practices, you're asked to see patients too fast. And a patient that complex as a Duchenne patient is not a patient that you can see in 15 minutes, right? So when that happens, you're losing a lot of things that should be discussed and that should be brought to the next physician who is going to see that patient. The problem is you don't have time to meet with that physician. That physician doesn't have time to meet with you. Like if you're thinking about neurologist to neurologist, right? That is a very complicated. So maybe transfer clinics will be an option. Maybe my model is an option where you don't actually transfer the neurologist. The neurologist is always going to be the same. What we have difference is that we have a team for cardiology and pulmonology under 21 years of age, and we have a team for older than 21 years of age. We do share the same nutritionists. We do share the same physical therapists, occupational therapists, respiratory therapists. And I think you could still share the team. But I think that if you have somebody like the neurologist, or somebody that is really holding the boat, holding the transfer of that patient, I think that's a way that we can organize this better. But again, the lack of time, the lack of institutional support, this type of medicine of neurology doesn't give money, doesn't pay well, because you spend too much time and you get paid like if you were treating a cold, right? But that's not reality. I spent an hour with each of my patients, and the rest of the team spent another 2 hours. So our clinics on Thursdays are only 6 patients in the day, and we spent around 3 hours with each patient. So nobody's going to pay for that, right? Unless you have people like foundations like Cure Duchenne, which they give you a grant and they support this type of practice. So I think that my dream and the model that should happen for not only Duchenne, but rare diseases is to have small centers that can really dedicate their efforts to these type of patients. And I can keep talking about, believe me, there are so many things that need to change, but the reality is that these people have a hard life. It is extremely hard, and nobody understands until you leave through and see them, right, in your clinic. Until I don't even understand. I have been with them for more than a decade, and I cannot understand how these mothers do at home with these patients, right, as they get older. How complicated it is to take a bath, how complicated it is to, get them clean, feed them. It's a whole ordeal. And then on top of that, our medical system doesn't support anything for them to make their life a little bit better. So I think that has to change, and that's what we're trying to do in our practice.